and welcome to Wooden Teeth, a podcast about truth-telling on politics and health. I'm your host, Jake Williams. Today's truth: providing people with the resources they need within their homes and communities is more cost-efficient and leads to better health outcomes than just relying on healthcare alone. And a program in North Carolina has demonstrated this clear reality. The North Carolina Healthy Opportunities Pilots was a program within Medicaid that was made possible through a federal waiver. In 3 regions within North Carolina, the program covered 29 evidence-based interventions that fell into 4 categories: housing, interpersonal violence and toxic stress, food, and transportation. So some examples of interventions included home remediation services such as mold removal, rental assistance for housing, transition services to help get people out of domestic violence situations, cost coverage for fresh fruit and vegetables, and reimbursement for health-related public transportation. These Healthy Opportunities Pilots, which I'm going to shorthand as HOP, were carried out in partnership with community-based organizations and served about 40,000 people enrolled in Medicaid. A study released in June of this year found that HOP saved $164 per person per month versus what it would have cost taxpayers if HOP did not exist. You might have noticed I've been speaking in the past tense about this program. That's because the program was suspended last year when the North Carolina state legislature didn't provide funding to continue it. However, as we record this podcast, the legislature is considering restoring that funding to reinitiate HOP, and we at Healthier United are participating in the campaign to make that happen. To help us understand how this program worked and what potential it still has to offer, we're speaking with Dr. Betsey Tilson. She's currently the Executive Director of Nurture NC, where she's working to improve maternal health, and she's previously served as State Health Director and Chief Medical Officer at the North Carolina Department of Health and Human Services when HOP was rolled out. Let's go talk to her. Dr. Tilson, welcome.
Thank you. I'm so excited to join you for this conversation.
All right, let's start at the beginning. How did the Healthy Opportunities Pilots get off the ground in North Carolina?
In North Carolina, we were struggling with really what the rest of the country and all the other states were struggling with, which was we're having poor health outcomes and rising healthcare costs. At the same time, we had this whole body of evidence to show us that although access to high quality clinical care is critically important, the importance of Medicaid and Medicaid expansion, sometimes while critically important, it's not sufficient. And we had a lot of data to show us that what happened in the exam room accounts for maybe about 20% of your health outcomes, and 80% of the health outcomes is those things that happen outside your exam room. So we really wanted to think about how can we use that evidence and that data to have a strategy that allowed us to buy not just health care, but to buy health, and really thinking about things like food and housing and transportation, and how can we more strategically invest in the health of our people.
So that was the concept. Then you actually had to, or at least a team of you had to get it actually passed through the legislature. You had to get a federal waiver, am I right? Could you talk a bit about the political process to actually go forward with this innovative program?
There were a lot of details, operational and political and legislative partnerships that we needed to go through. First we had to figure out what did we want to do. So we knew we had this problem. We knew we had the evidence. First, we had to really think about what would be the solid plan of what we wanted to do. And one of the things, and we started again with the data and the evidence. And a lot of the evidence showed that there was effective programs that were on a smaller scale and siloed. So maybe one hospital or one clinic or one study showed this. What we realized we needed to do was, how do we build an infrastructure that really could be scaled across the state and do this on a population level? So we had to think through, what do we want to do? Then we had to think through, what are the operational capabilities we need to do, and where did we want to focus? So the first piece was just design and plan. Second is that we worked really closely with CMS to think through what would CMS need to see to approve this plan. Because as you know, Medicaid is a shared program between the federal government and the state governments. And if we did want to do this through a mechanism called an 1115 waiver, which is what we did, that needed approval by the federal government. So we worked very closely for more than a year with CMS to say, what did you need? What would you need to show? And they were very supportive of the idea. They really wanted to be sure that we were very accountable in terms of our evaluation, and also making sure that we could show a getting out of the fee for service kind of gerbil spin and get more to a pay for value. So that was the first thing, work with our federal partners on designing this and make sure that we have those elements for their approval. Then really working with our General Assembly members, making sure they understood our plans, our intentions, making sure they knew we were aligned with CMS. And so as a reminder, we did this a while ago. So this was the first Trump administration that we worked with on designing our 1115. So really working across the aisle, working with our General Assembly members once we had the plan with the Trump administration to think through the state share of that. And then working with so many of our community partners in really thinking about how to implement this. So we really had everybody involved across the aisle, from the state, the national, the state, and our community level to design this and get it ready to deploy.
So this program includes several community-based organizations, and in the traditional Medicaid system, I know there are a lot of partners for reimbursement as well. But how did you approach selecting who to involve in this program? And were there new challenges or opportunities with this new constellation of groups?
That's one of the most exciting part, was bringing more people to the table than traditionally we had as part of having Medicaid reimbursement. As you said, typically the Medicaid covered services are very clinically oriented service. Again, we were redefining what health services was, and that meant bringing more people to the table and more organizations to the table. So first we said, where is the evidence that studies have shown that if you pay for these services, you incorporate these services, there's evidence to say it'll improve health and it'll decrease healthcare costs. So we started with that first. And that got us to our four core domains of food, housing, transportation, and interpersonal violence. So we started with the data, started there. Then we realized that to make this effective, it really needed to be embedded by the communities and informed by the communities, because they are the ones who knew who the providers were and how they would implement this on the ground. So what we did was we identified those domains, and then we identified through a competitive RFP process who would be what we called the network leads. And we weren't doing this statewide. Our first 1115 said we would only do it in 3 areas of the state. So we did a competitive RFP for a network lead that were already on the ground. And that network lead's responsibility then was to create a network of providers that could deliver those services that we had defined in food, housing, transportation, and interpersonal violence. So that network lead and that glue of that network was critically important. So they were the ones that then identified and brought those providers into their network and helped us to operationalize it through that. The challenges these were new providers that hadn't intersected with Medicaid or Medicaid managed care plans. These were our churches. These were our food banks. These were organizations that hadn't been paid by Medicaid, and that Medicaid managed care plans hadn't really intersected with those organizations, and the organizations hadn't intersected with the health system. So that was the importance of the network lead, helping to translate and connect to those organizations. Things like invoices. How do you generate an invoice to a managed care plan? How do you pay an invoice? So there were so many of those granularities that we were able to work out through those pilot pieces. So the challenges, because you were getting sectors together that hadn't been together, but the opportunities and the successes have just been incredible to have a church that has their community gardens, and those community gardens, then the produce from the community gardens then are bundled up into the food boxes and delivered to people by the church parishioners. The success and that integration on the community has just been amazing.
So Dr. Tilson, you may have noticed that we live in polarizing political times.
Mm-hmm.
And so first, it's amazing that this thing got off the ground with bipartisan support. Mm-hmm. And within Medicaid, I'm sure you're aware that part of the debate that's been had, usually on a partisan basis, is that one side contends that there's too much waste, fraud, and abuse within Medicaid. And I think all of us don't want that, right? But I'm wondering with this program in particular, given that you had to, include new partners who may not, probably for the most part, had never, like you said, been reimbursed by Medicaid, and you have to follow certain rules because these are taxpayer dollars. Were there challenges to make sure that everything was tight and accountable? What was that experience like with these partners?
I promise I'm going to answer your question, but I want to just do a little contextual thing.
Yeah.
The the goal of the first 1115 was to really test and learn and pilot and identify all the things that you were just bringing up. This is going to be a new way of delivering health services. So we really were in the mode of testing and pilot and learning and continuing to improve. And we chose some of the kind of hardest places to do this. So our three pilot areas are rural communities across North Carolina that maybe didn't have the resources or the infrastructure. So we kind of started in some of the hardest places to figure if we can get it to work efficiently there, then it's more easy to scale. And the importance of this network lead that I was describing really was critically important to ensure that the program was working the way that it was intended. And so, for example, we had a way to set up invoices. Those invoices then were going from the community-based organization into the network lead first. They were doing a lot of the quality assurance, the quality checks. Are this right? And making sure that invoice is right before then it went up to the Medicaid managed care organization before payment. So there were so many places that we did proactive technical assistance so people didn't fall into traps or errors they weren't intending. And on the back end, making sure we had that quality control to be sure that everything was accurate. So we had a lot of those checks and balances by design. We also invested up front. I think this is a really important point. Before we expected people to start delivering services in a way they've never delivered it before, we invested some upfront money in capacity building. So some of that technical assistance training, some of that investment in the systems, we really wanted to set everybody up for success, not for failure. So there was a period of capacity building where we tried to anticipate where the trips and where people may not have that capacity. Let's build that first, then continue to give that ongoing TA and then do the back end. So we had a lot of places that we were trying to make sure that the program was run as efficiently and effectively as possible.
Thanks for getting into the weeds there with me for a second. It's those are details, but I think important ones for people to understand about programs like this, especially in this climate and this current debate that we're having about the Medicaid program. It sounds like you guys really were smart in terms of giving the resources that were needed to stay compliant and accountable up front. And it seems like it worked out. Let's talk about how it worked out, actually. The state recently released a report showing great cost savings per member per month and better outcomes. Can you talk a bit about, and be honest, what were your expectations for the program going in, and how did those end up aligning with the results that were documented by this report?
Yeah, I will go into more detail, but I think the headline was our success way outstripped my expectations. I cannot actually believe, every time I see more and more of the data, I'm like, I designed it like I expected it to work, but it has worked so much better, I think, than any of us really anticipated. It's been amazing. So I'll come back to that, but that's the headline, is it's been amazing. So I really thought this was the right play. We had so much data to show if you want to improve health and decrease costs, you need to continue to invest in high quality clinical care, but you've got to start investing in the places that we know are driving healthcare costs. So I felt very strong in the evidence and the base and the rationale for doing this. The first piece was, can we actually operationalize this? We're creating a whole new health system. Could we actually efficiently identify patients, deliver services, do this in a way? And we were incredibly effective in being able to create this new health system and really effectively delivering services, paying invoices within 45 days. Like, we were very able to create a very efficient structure in delivering services. In fact, even the evaluators, you could read in some of the early evaluations, like, they actually did it. They actually could. I think they weren't even thought that we could actually do it. So that's the first thing, is can you create an effective, efficient system? Yes, you can. Can we actually improve the lives of people by doing this? Are we getting at the things that we thought was core to people's health, but could we? And yes, we could. And you'll see that people will say we got stories back from people saying this was life-changing. This was a blessing. This completely has changed everything that I'm doing. Like the testimonial and the impact of actually people as humans and people has been profound. And every time I think about it, I get a little bit of teary-eyed, because I think the whole point of us in public service is to help our people. People felt helped, and it was truly received as a blessing from them. Amazing. And we were decreasing their social risks. So the things that we were trying to do, we actually decreased their social risks. Then we posited that we're going to be improving health and decreasing healthcare costs by making sure that people, A, were getting what their needs were, and then they were navigating the health system in the way that it really was designed. So getting their social resources, but also utilizing primary care, the right place of care. And we saw a shift in that utilization. People were going to primary care, and then we were seeing a drop in hospitalizations and ED, emergency department visits, which we posited that was going to be the case, and that turned out. And then all of those together then came with the cost savings, which is $164 per member per month. And for those of you who are listening, when we think actuarially and what is a PMPM, or a per member per month cost saving, 164 PMPM blows the doors off of any other program in terms of cost saving. And in fact, the more we've had multiple interim evaluations, and each time the evaluation is done, more cost savings are found as we have more people in the program. So outstripped my expectations. And every time I read it, I can't actually believe that we had this much money that was saved, and all of those kind of things that we thought were going to be moving to the cost savings, like the utilization and actually people's health being improved. We saw all that happen. So unbelievably satisfying and exciting.
So the program was paused, unfortunately, last year, but now it might come back pending decisions made in the North Carolina legislature as we record this podcast here on June 17th. Let's say it gets back online. What are the additional opportunities for learning and improvement?
Yeah, the program was paused, and we still don't have a state budget, and so that the program was paused. I'm very optimistic that when we get a new budget, and especially with the strength of this new data, and really, to be perfectly honest, the kind of common sense rationale, you have a lot of conversations across the aisles that I think people get, if you had $100 and how are you going to invest that in health? It makes a lot of sense that we need to be sure that people have food and have a house and have transportation. And so there is a lot of common sense piece to this, and then coupled with the incredible cost savings. And I'm very optimistic that as we go forward, this will continue. So lessons learned. And again, we started this as a pilot to test very strong evaluation component with interim evaluations, continuing to learn, continuing to figure out where we're going to tweak. So that will be continuing. And I think we've learned a lot, and we'll continue to learn if and when we can reignite this and expand this. I think a couple of things that we need to learn. One, we have figured out how to do this in some rural areas. One thing I will say, not only the evidence that I shared, but another piece of the evidence is that we have invested in our local communities and in our rural communities. So not only are people better off in the Medicaid program, better off, but because we've infused resources in the communities with these community-based organizations, our communities are better off. And they have now more economic viability in their communities. Now people can have more jobs by these now funded organizations. So the power of this to infuse the economic stability, especially of our rural communities, is yet more of a win-win-win. So the success of that, I think a couple things is that how do we scale this even more statewide? How do we think about if we're going to do more urban communities as opposed to rural communities? What does that look like? Because I know our rural areas are different than our urban areas. So how might we want to tweak this if we're doing it in urban areas? I think we also need to think about, and this will happen when we have more people in the program getting more services and more time, is doing a little bit more of a segmentation of if this person has this set of risk factors, what is the right set of services for that person? So get even more defined and even more tailored on what is the most effective set of services for a person with these different risk factors, or for pregnant women as opposed to children, as opposed to adults or non-pregnant adults. So we just don't have enough of what we call an N, enough of people in each of those subcategories to really get it as precise as we would want. So I think that's another learning as well, is how can we get this as tailored and as precise as possible. So I think those are two learnings still that we want to think about. And then I think spending even more time on how can we be sure we're effectively investing in our communities above and beyond what we've learned in our rural communities. Because I think using the power, I think about this, the power of public purchasing to really boost the economic viability of our communities is really powerful. So I think there's more to think about that, and how can we leverage this investment to the benefit of our community writ large. So those are three areas that I think we can still learn from.
So this program isn't really healthcare. It's not services delivered in a doctor's office. And I don't think you can say it's like capital P, capital H public health, as in centralizing the involvement of the public health system. It's something in between. It's community health. But my question is, by engaging community members in this way with community-based organizations, do you think that there's opportunity to build trust in helpful ways? For example, as we both know, there's increasing skepticism about vaccines, for example. Like, do you think this program is a way that by being closer to communities with perhaps trusted voices, we can build institutional trust in ways that can benefit public health?
100%, yes. And I think about public health as the health of the public, right?
Yes.
And that's what we're trying to do. And so the health of the public, we need to think about cross-sector and not silo it into these potentially more partisan pieces. But if we think about what we're all trying to do together is improve the health of the public, I think that gets us to a better conversation part. Two, I think that when we think about the health of the public and the health of our people, then those are the people that we really need to invest in and empower in, and have them be in control of a lot of programs of the intersection. That's where the power lives, with the people in the communities. And that was one of our design pieces. Now, I think it's going to get to your point. I think that is an added bonus of the trust, but fundamental in our design was that we wanted to be sure it was these community-based organizations that were delivering the services. One, they just know their communities better. We wanted to be sure the resources were getting to our communities, not necessarily big national companies. And three, it is that stickiness that we have found is an added benefit to the program. And let me define the stickiness, which I think it gets into the trust piece. So I was using the example of one of our churches that has a community garden. They package up these healthy food boxes. Then that church or that church member then is going out to the home and doing a home delivery to this person. It's not necessarily always the most efficient way of delivering services. Like maybe we could have done it that we had a drone, drop the food box on the, and there's been conversations about that. But it is that person to person and that connection that has those additive elements. So you have the food box, but then you have a person going to the house of a person who maybe is socially isolated, right? And you have that person to person connection, and they deliver the food, but then they have the conversations about other things, and that they build that relationship and they build that trust, and then they can connect that person into other resources as well. And so that stickiness of that person to person and on the ground piece was incredibly important. And one of the things that the data showed us was that the longer somebody was engaged in the program, the more savings, there were more healthcare cost savings, because they were connected into a system and a trusting relationship, and then were able to navigate and take advantage of some of the other resources as well and get more into that holistic care management. So yes, it is all about trust and relationships and in communities and understanding communities and having that person-to-person connection. So yes, by design, it worked beautifully. And I think that can translate into other things we're trying to do to improve the health of our people.
This program is based on things we've already known about for a really long time. We've known for a really long time that, most of the inputs that lead to our health outcomes is stuff that occurs in our homes and our communities and not in the doctor's office. We know that the large reason why we have lower life expectancy here in the US versus other OECD countries, despite the fact that we spend more on healthcare, is because, again, we don't make those investments upstream to make people healthier in the first place. And so if you look at healthcare spending, you're kind of sort of missing the point. Yet, these sort of programs are still at the vanguard and new. What took so long? Why did it take so long to have a program like this, not just in North Carolina, but in the United States?
Several pieces in there. I think we have a kind of a mindset in the United States that healthcare and medical care it's very medical. We haven't really made that cognitive pivot to think, even though we have the evidence, we haven't made that pivot to say, yeah, food is medicine. Housing is medicine. It just hasn't, I think, gotten into our mainstream mindset that this is health. We talk a lot about healthcare. We don't often talk about health. And so I just think there's a kind of a cognitive thing that we haven't made that switch as a country to really think about this as healthcare and as medical care. So we thought a lot about the language and how we're phrasing this and thinking about that, again, I went back to, we want to think about a strategy of not just buying healthcare, but buying health. So I think there's just a piece of it is us just thinking through this as true foundational, legitimate healthcare expensive. So that's one piece. The second piece is that, yes, we had the evidence that these worked, but as I mentioned, they were siloed and maybe one healthcare system or one study. And we really had to think about building the infrastructure to scale. And that's a whole other lift. Like, we knew it was right, but what hadn't been done was, what is all these operational capabilities and infrastructure pieces that we would have to build? So it's just a kind of a different mindset too, that a lot of times as health and healthcare people, we think about what are the services, but we don't think about infrastructure, right? And shared infrastructure and capabilities and those pieces. So we had to really shift. Like, our job wasn't really to say, do people need food? Because it turns out people need food. Yeah. It was really thinking about shifting from a health and human services standpoint, we're going to build infrastructure, right? So it was just a little bit of that mindset. And then we embraced this idea of radical pragmatism, right? That, like, we know this. We weren't trying to, like, change everything and make this perfect thing from day one. What's just this idea of radical pragmatism, that we could just start chunking away at what we knew and how could we actually operationalize it? And then there's also leadership, very much leadership. We had support and leadership from CMS and the federal government. They were on board with this concept. That's amazing. When we could work with CMS, we had amazing leadership at the state to say, this is the right vision. We had partnership with the General Assembly. So it's also alignment of your governmental agencies from national, state, legislative, and executive branch saying, yep, this is a priority and we're going to do it together. So you have to kind of have all the stars, I think, aligned. And then the willingness to say, yeah, we're going to work on infrastructure. Infrastructure doesn't say, I love infrastructure. They don't always teach you that in medical school, but I love that idea of what's the system that we can build and what's the infrastructure we're going to build. So I think it just kind of takes a little bit of mindset. Let's get out of our silos and really think about what do we need. Everything was kind of aligned in North Carolina and the federal government at the time that allowed us to experiment and think about how do we do this differently.
Dr. Tilson, this has been fantastic. Thanks for your work, and come back again soon.
Great, thank you.
Thanks again to Dr. Tilson for joining us. Please rate and subscribe. Hit all the buttons to help get the word out. I'll see you next time on Wooden Teeth.